I'm Zach Mesberg. This is a brief presentation on blood gases. We'll touch briefly on some other labs that help to kind of help you understand and interpret a blood gas reading. Who here can tell me, who here has ever spent any time looking at arterial blood gases on a patient? Ever maybe looked at a report from a hospital or had some time in critical care transport and has any clue what we're talking about before we even start talking? Anybody? I'll take that as a no. What about you, Mike, sitting in the room?
No, not really.
Okay, so what we're going to cover is, here we go. We're going to cover what an arterial blood gas is and what it tells us. And to qualify this before we begin and get into depth, arterial blood gases are a very complex subject of which I certainly do not know everything by a long shot. I think if you were a critical care physician, you'd have a much greater breadth of understanding and ability to talk more about this, but honestly, it would probably be more than we would care about as paramedics. So I'm going to try and keep this. I have edited down the most common technique for interpreting this, or I think the easiest technique, down to EMS size, and hopefully that will be enlightening for us. So we'll talk about what the components of a blood gas are, and we'll go over a basic strategy for interpreting them, and we'll talk, as we do that, about correlating that to disease processes that we're familiar with, and then we'll briefly touch on venous blood gases, and then we'll be done. So first off, what is an ABG? So when you get an ABG on a patient, typically it's obtained one of two ways. The most common way we would see it in the emergency room setting would be drawing usually a radial arterial blood sample from a patient. So often you'll have the respiratory therapist do that. Technically, I believe for 2 or 3 years ago, that was actually added to the Oregon paramedic scope of practice, although I'm certainly not aware of literally anybody in the state of Oregon doing that. I'm not quite sure why that was added to the Oregon paramedic scope of practice. But theoretically, you could, not in Multnomah or Clackamas County, stick a small needle into somebody's radial artery, draw blood, and then send that for sampling. Or I suppose sample it yourself if you had an iStat that had the cartridges necessary to do this. And so who knows, maybe in the future, something like this could happen. And remember, you can also get a venous blood gas sample, which is literally just a venous blood draw that you run through the same analysis. And the analysis you do is actually a lot more similar than you would think. So when you run this sample, and the other way that you can obtain these blood samples is typically from an already in place arterial line. So either if the patient has a radial art line, like something you'd use for continuous blood pressure readings, like in an ICU patient, or maybe somebody has a Swan-Ganz catheter, or somebody has a femoral central line. You could sample through the central lumen an arterial blood sample. And typically speaking, the most common use that we see for these is either in the emergency room, somebody who is suspected to have metabolic derangement or is in respiratory distress will take a sample at initial presentation to try and make a diagnostic analysis of what's wrong with the person. And then based on that and other findings, do things to the patient, specifically like the most common thing we would think of is like intubate them and put them on a ventilation strategy. And then we'll look serially at blood gases over time to see if what we're doing works or not, if we've set the ventilator correctly, if we've given medications correctly, and if we're essentially making a positive effect on the patient's condition. So typically when you look at blood gas results, you're going to see 5 to 7 or 8 things. Only 5 of those things are actually part of the blood gas, although a few other things typically get sampled because they help us to make some other extrapolations about what the blood gas means. So we see PaO2, PaCO2, pH, bicarbonate, and sometimes SaO2. And so we're all, I think, familiar with SaO2, which is literally just oxygen saturated. And this is going to be used from analysis of an actual blood sample, but it's the same rough number that you get from a pulse oximeter. Literally, of all the red cells the person has, what percentage of those are saturated, what percentage have their hemoglobin bound with oxygen. Now, PaO2, I'll stop for a second. Can anybody, obviously it's up on the screen, what does that really mean? What does PaO2 mean, and what unit is it expressed in? Does anybody know? Don't be shy. No, not quite. Anybody, any other guesses? So PaO2, literally like it says on the slide, is partial pressure of oxygen. And what that literally means is an actual unit of how much oxygen is physically dissolved in the patient's serum, in the blood, and so forth. And it's expressed as millimeters of mercury. So a typical, we'll go over that, we'll talk about typical values, but PaO2 gives you a much better picture of actually the patient's oxygenation status than SaO2 because you could have a lot more oxygen in your blood than is bound. Conversely, PaCO2 gives us a picture of ventilation. Then we have bicarbonate. And so bicarbonate is a component that comes from your renal buffering system. So now we're getting way back into paramedic school into that
Alexander Goldman
really remember
has
anymore.
Left the meeting.
I don't care if you do. Oh God, things are getting confusing. So anyway, bicarbonate is a picture of the body's response to a metabolic derangement that you may or may not have. And we can know some things from these numbers without really doing any analysis that can actually be fairly useful to us as EMS providers. Let's say that we show up to transfer somebody who's on a ventilator and we have a recent blood gas reading. The big one is easy. So from PaO2, we can say at 100% saturation, is this an appropriate level of oxygen we're delivering to the patient, or is it far too much? Are we hyperoxygenating this person inappropriately? We can look at their CO2, and CO2 is going to give us a good picture of how well we're ventilating the patient. And remember, we always think about CO2. We love to talk about CO2s nowadays with capnography, but you have to understand, and I think most of us know, that the number you get from waveform capnography or numeric capnography is not necessarily an actual good picture of what's going on with the patient's essentially acid-base balance or with the patient's ventilatory status. It's usually the best that we have, but if you can actually have an arterial blood gas that gives you a CO2, then regardless of whether the person has some impaired circulatory status or they have DQ mismatch, we can essentially know, really, are we ventilating this person appropriately? Is there a ventilatory derangement? And if so, delving a little deeper, what may be the cause of that? And then the other thing that we can get a better picture into with blood gases is we love to talk about, the patient being acidotic. So, Tim, if I may ask you a question, what does acidosis mean?
So looking for the pH value, that it's lower than 7.35.
Sure. I mean, so we would typically say, when we talk about this as medics, we use the language as medics, we typically say somebody's acidotic or alkalotic, and we mean we're making a presumption about their pH being low or high. But really, in proper form, we would say acidosis is the thing that's causing their pH to be high versus alkalosis, that's causing their pH to be low versus alkalosis, the thing that's causing their pH to be high. And in certain states, especially as the patient compensates, somebody can be clinically acidotic or alkalotic, but have a normal pH. Now, by definition, if that process goes on long enough, their compensatory mechanisms will fail and their pH will change. But with a blood gas, especially if we know how to interpret them, without even really very deep interpretation, we can look and we can determine that someone is in an acidotic or alkalotic state that is compensated for and is essentially not yet presenting in the actual pH. And so that's another thing that we can see that we're never able to figure it out just from looking at a patient in the field. And so let's get back to PaO2. So PaO2 is partial pressure of oxygen dissolved in blood. The normal range is 80 to 100 millimeters of mercury. That's at sea level breathing room air. So there are formulas that you can use to determine how things will change when you're not at sea level, because obviously the dissolved concentration of oxygen in the air, room air, is only 21% when you're at sea level. Luckily, we're at sea level here in Portland, and we're not running a flight service here, so we're not going to worry too much about changes in that for our purposes. Now, you can actually estimate and when I say normal, I think a better word would be expected, what expected FiO2 would be given ideal circumstances as we increase the patient's oxygen. So if the minimum normal is 80 to 100 millimeters of mercury at sea level, we can just make it easy and call it 100. If you drop below 80, you definitely have a problem. If you're over 100, you don't immediately have a problem, but it's essentially hyperoxygenation at that point, and that may be non-ideal for you for a stroke patient maybe, or for somebody having an MI. And this is why you've seen, for example, AHA guidelines most notably be revised in the last several revisions to say, instead of just putting the patient on a non-rebreather mask at 15 liters, we would like to shoot for a goal SaO2 of essentially 94 to 99%, or 94 to 98. Because once you hit 100, we no longer know. If you're below 100% SaO2, we can pretty well be assured we have some sampling problem with our actual fingertip oximeter that we have exceeded 100 millimeters of mercury of PaO2. But once we're at 100 SaO2, it's kind of like I'm not even sure, honestly, what the theoretical maximum is. I mean, I would say right around 500, but I'm guessing under some circumstances, especially when we talk about atmospheric pressure, we have to go higher than that. And that's not necessarily an ideal circumstance for some patients. So let me ask you a question while we're on this. Can anybody tell me a circumstance where we would actually want our PaO2 to be as high as possible. So like let's look from an EMS perspective. When do I want that PaO2 to be? Literally every oxygen molecule I can cram into a patient. There's some times that I would really like that to be the case. One comes to mind particularly. Can anybody throw that out there? Feel free to throw that out there. No? Nothing?
Carbon monoxide, please.
You know, that would be a good one, although frankly, I don't know how much of a difference clinically that would make, because the problem in carbon monoxide poisoning is an oxygen transport problem. And essentially, even if we have a lot of extra oxygen in the serum, that's not necessarily being effectively utilized by the body, because essentially we can't transport it on the hemoglobin at that point. It's bound to CO instead. So the one that comes to mind immediately, and it ties back into another lecture that I've done in the past, is pre-RSI. So in other words, when we talk about nitrogen washout, there can only be so much gas dissolved in the blood. And so in other words, the more oxygen you add into the blood or serum, the less CO2 you're going to have, and the less other gas, less nitrogen you're going to have in there. And so we talk about denitrogenation or pre-oxygenation, pre-RSI. What we're attempting to achieve is the maximum theoretically possible PaO2 prior to starting the procedure, because that just essentially buys us more time before the patient desaturates. Because even if if the red cells are 100% saturated, but we are only at a PaO2 enough to saturate just the red cells, as we desaturate those cells as they go through the circulatory system, there's no reserve to replenish them with. And and honestly, it doesn't buy you a huge amount, but this buys you some extra time prior to a critical desaturation in a patient.
Either effectively shortening or elongating that safe apnea.
Exactly. And so the higher the PaO2 is, the longer that safe apnea period is, relatively speaking. That's why we also do things like apneic oxidation that will help to actually prolong that high serum concentration beyond what we would normally consider to be physiologically feasible. Right. And so the easy way to think about this is the approximate ratio between FiO2 and PaO2 at sea level with normal lung function is 5. In other words, if I'm giving the patient 100% FiO2, I multiply that by 5, that gives me 500 millimeters of mercury PaO2 under ideal circumstances, and going down from there. So I was giving the patient 80, and I'm not going to do the hand math because we'll get it wrong and I'll be embarrassed in front of you guys. 80 times 5 is some other number less than 500. That is my theoretic PaO2 when the patient's had full time to oxygenate and they're breathing that oxygen reliably, assuming we had something like a Venturi mask, or we were most reliably then down a ventilator, literally actually controlling exactly how much gas blend they get, how much oxygen goes into the patient. And so that's PaO2. Any questions about that before we move on? No? So the next one is PaCO2, which is, once again, partial pressure of carbon dioxide dissolved in blood. And I think this is a range, if you polled most medics in the modern day, that we're relatively familiar with, because the normal range is 35 to 45 millimeters of mercury, which is what we see, what we're kind of shooting for when we're looking at an EtCO2 or an end-tidal CO2 in the patient. And PaCO2 will roughly correlate to end-tidal CO2. It's plus or minus 2 to 5 millimeters of mercury normally. So we're assuming, if that's the case, we're going to make a couple assumptions. We're assuming that the patient has an appropriate volume status, their pump is working appropriately, and they're exchanging gas normally at the lungs, and there's not a major metabolic derangement that's making a problem with oxygen onloading and carbon dioxide offloading, which is a lot of assumptions to make. But essentially, if I took any one of you sitting here normally, maintaining homeostasis the way we'd like you to be and not actively dying, and we sampled your PaCO2 and we put you on an end-tidal cannula that was working properly, and we sampled your EtCO2, the numbers should be roughly the same. But there are some times when the numbers will be widely variant. So for example, who here, I'm sure, because I can't see the list anymore, we've got a lot of longtime medics in the room. Many of you have probably seen somebody having a life-threatening pulmonary embolism, somebody with a close to death, a patient in extremis with PE. So these patients, or maybe for another example, probably if you haven't seen that, you've seen somebody with a really bad obstructive shock from maybe a tension pneumothorax or something along those lines. In any one of those situations, typically, what is the number of end-tidal CO2 that you see? If you have them on a cannula, which I would advocate that you should, what numbers do you get? Do you get high numbers or low numbers? Low numbers, typically. What would you expect if I could sample their arterial blood that we would actually have? We'll have exactly very high numbers, because typically they're not exchanging gas well. They're not actually offloading CO2. We would expect that they have, depending on what we're talking about, either a respiratory or a metabolic acidosis or a mixed acidosis. And we don't see that on the front end, because essentially part of the reason that they have that is because they have a failure of gas exchange. And either the failure of gas exchange is on the front end, like we have a pulmonary edema patient where literally they have fluid in between the air space and the vascular space, or we have somebody who essentially isn't putting enough vascular blood, not enough blood's going to the back end of the pulmonary space, or for whatever reason, we have VQ mismatch, ventilation perfusion mismatch, and we don't see a good end-tidal CO2 that actually correlates to a PaCO2. And there's one other situation that will also really derange it, although maybe not as clinically significantly as we would think, given a circulatory problem, which would be somebody that has primary respiratory disease. So in other words, think about like your patient with COPD who's we'd say a chronic retainer, which literally means the person has an elevated, PaCO2 all the time. So sometimes, especially if we're ventilating those patients well, we'll see high numbers coming out of them. But sometimes you'll see low numbers coming out of these people. And just because your severe COPD patient who's exacerbated is giving you low numbers doesn't necessarily mean that they actually are effectively ventilating out what they should be. So, for example, one of the things that we may see a lot, I notice this very commonly in my own practice as a paramedic, you have the patient who's a COPD exacerbation, who's critically ill, and you put them on CPAP and you have them on an end-tidal cannula. Typically, if your end-tidal cannula is sampling appropriately, which can be a little tricky with CPAP, what do you see with your end-tidal CO2? I'm going to have to pick on you again, Mike. What happens?
It doesn't wash out. You tend to the number will drop.
So I would say if things are working correctly, because remember there's a little bit of sampling errors, but if everything's working the way it's supposed to be, your end-tidal should actually go up as you recruit more alveoli, because this person has a huge reserve of actual dissolved partial pressure CO2 in their blood. As you allow them to ventilate more, you see more CO2 coming out of the front end. You see more CO2 coming out of the cannula, which doesn't mean that they're getting worse necessarily. It can mean that they're getting better, or at least staying the same. So that's just something to think about, and that's why, once again, if we could sample that number in the field, or if we were transferring somebody and we had a recent sample that had that value in it available to us, we would do well to look at it and to consider how that corresponds to our patient's current clinical condition and the treatment they're receiving, whether that treatment is effective for them or ineffective or needs adjustment in some way. Any questions about that before we go on? So the next thing is pH. And so I think that's another number that if we paid attention in paramedic school, most of us know the normal pH range. With normal pH ranges, says it right there on the screen, 7.35 to 7.45. So what does that actually mean? What is pH? Anybody I don't know if you guys out in the world can talk back to me at all or can send a message, but can anybody, I'll give you a minute or 30 seconds to respond. Can anybody tell me what pH actually means? And there's some stuff on the screen, but if you aren't up on your chemistry, it probably won't help much anyway. What is pH? What does that number indicate? Like, it's a number. How do we get that number? What does it mean?
Measure hydrogen.
Exactly. pH is hydrogen ions. Specifically, it's a formula. It's you take the negative logarithm of the serum concentration of hydrogen ions expressed at millimoles per liter, and it gives you that number, which is 7.35 to 7.45. And 7.35, if you're below that number, we would consider the patient to be clinically acidemic, and we would assume acidotic as well. Like I mentioned earlier, acidosis can be present without acidemia. If you are acidotic for long enough, and sometimes in certain circumstances, or if the cause is bad enough, it doesn't. When I say long enough, we're talking about minutes, but it can be hours or days depending on the underlying cause. You're acidotic if your pH is below 7.35 and you're acidemic. And conversely, you're alkalotic and alkalemic, but definitely alkalemic and alkalotic if you're over 7.35, and maybe alkalotic but not alkalemic if you're not. Does that make sense? I know it's a little confusing. We'll talk about it. So for example, to go back to PaCO2, because we can somewhat, and we'll talk about bicarb plays into this a little bit as well, but with PaCO2, let's say I have a patient that has a pH of 7.4, and they have a PaCO2 of 70. What does that tell us about that patient? I'm not going to, once again, I'm just saying a range of things. So that's notwithstanding clinical findings, underlying cause, other labs. we have a CO2 of 70 and a normal pH. Is the patient acidemic in that case?
Yeah, the body's just compensating.
Well, so they're not acidemic, but they are certainly acidotic. So they're essentially exhibiting compensated respiratory acidosis, but we are not yet acidemic. Our pH has not dropped below 7.35. But what would be the expected course of disease should that compensatory process continue without correction of underlying cause? Exactly, then our pH will drop. What we're watching the respiratory buffer system essentially work its way through trying to maintain homeostasis. And at some point that will fail. It gives us a clue that we have a problem, but we're still in a compensatory phase.
So maybe can you give the definitions of acidemic versus acidotic?
Yeah, absolutely.
So
I would be happy. Okay, so acidemia is literally defined as a patient with a pH that is below normal range. In other words, below 7.35. That is the definition of acidemia. It's essentially a finding based purely on a lab value. Acidosis is the clinical condition of producing excess fixed acids, which your body may or may not be compensating for right now. So if you made it like I should have drawn a Venn diagram. It'd be perfect, right? It is a Venn diagram, right? So all patients who are, and the problem is there's like a part that doesn't mean anything, and I don't know how you do it. And once again, I'm not a presentation guy, but if you had a patient who was acidemic, all patients who are acidemic are acidotic, but not all patients who are acidotic are acidemic. We would infer that without intervention, these patients will become acidemic, but we are not there yet. Does that make sense? And the same for alkalosis, although frankly, and to be clear, there are some alkalotic processes usually related to overdose that certainly can kill the crap out of a patient, and we would care about. But especially from our, because most of this, we think about this from a paramedic perspective, because we're not going to be doing things pretty much ever like, oh, we need to start a bicarbonate infusion on this person. We're not likely to be doing a lot to impact their condition beyond ventilatory stuff. So we're a lot more worried about acidosis than we are about alkalosis. So there's a really common alkalotic condition we see all the time as medics, and we really usually are annoyed by it. What is that? Who can tell me what the most common alkalotic condition we see is? Say what? It's a panic, exactly. The patient who's hyperventilating, they have carpal pedal spasm. So these people typically, I mean, who knows how well you can really hyperventilate. Some people are really good at hyperventilating themselves, but typically that would be an alkalotic state that would not become alkalemic. In other words, they will lose consciousness and start to breathe normally when their CO2 is so super low, far before they ever really change their pH. But with that low CO2, we start to see problems with muscular contraction, maintenance of consciousness, and the people essentially, for lack of a better descriptor, have a syncopal episode and then not have that psychogenic stimulation and then start to breathe normally and then sometimes wake up and do it all over again, much to the annoyance of the ambulance crew. But usually that's a problem that can be fixed with, benzodiazepines versus anything else. Does that make sense? Tim, does that answer your question?
It does.
Okay. So back to pH. So really that's all I have to say about pH. We care about pH. If we could see a pH on our patients, we would like to do so. And once again, if that information was available to you on transfer, I would take the time to review it. The next thing is bicarbonate. So this is where things get weird. This is where I had to kind of pull some things out. First of all, because I'm not even sure that I understand this the best way to tell you. So we have our renal buffering system. I think if we think back to paramedic school, if we weren't sleeping through that part of class, we remember that your kidneys play a very important but slow role in maintaining normal pH in your body. And the way that your kidneys do this is by secretion primarily of bicarbonate, HCO3, which is actually HCO3 minus, but I'm just going to type, I got sick of typing that into the computer, so we're just going to call it HCO3. I think it's fine. Bicarbonate, bicarb. Just like the stuff we carry on the wall, that is sodium bicarbonate, because remember, this is a buffer. This is what? So in other words, if hydrogen was a negative ion, essentially this represents what? It's a positive. This can come together with hydrogen. Say what? Wait, I'm sorry, you're completely correct. See, this is like I shouldn't do chemistry, right? But in other words, this is the opposite of the hydrogen that you have floating around in your body. When you have this cannot literally exist free in any stable form. That's why we don't just literally inject people with bicarbonate. We inject people with sodium bicarbonate, which has the function of creating free bicarbonate in the serum, and also the addition of sodium, which is why things sometimes sodium bicarbonate is also used for certain overdoses that have really, really bad sodium channel blockade. Like, for example, as we learned recently, that I didn't know, and I think nobody around here knew, Benadryl is a really, really strong sodium channel blockade action in severe overdose. But the reason that you would be giving, or for example, another one we think about is aspirin overdose. So we would give bicarbonate in aspirin overdose, partially because aspirin overdose is acidifying, but also because we have a lot of sodium channel blockade, and we need to separate that bicarbonate from the sodium, and the sodium is helping. But that's neither here nor there. So in other words, when we're talking about bicarb in the sense of a blood gas, what we're talking about is an indicator of what the kidneys are doing to attempt to rectify a metabolic derangement. And one of the things that we can see is that, so a normal range of bicarb is 22 to 26 milliequivalents per liter of serum. If you have a person in a severely acidotic state and they don't die from it right away, or it develops slowly, we can see really high bicarbonates. We can have somebody be acidotic and not really have a whole lot of bicarbonate going around, because essentially it doesn't happen that quickly. Your kidneys cannot dump out an unlimited amount of bicarbonate. The other way that your body compensates for acidosis or alkalosis, but primarily acidosis, is what? Respiratory. And so when we say respiratory, what is your body doing? What's happening? Yeah, you breathe faster. Your respiratory centers tell you need to breathe faster to essentially eliminate what? CO2, to attempt to affect, once again, this very complex formula, which I thought about putting in here, and I decided that if I put it in there, somebody might ask me about it, and I would screw up my chemistry. And yeah, let's not worry about that. You all saw that in paramedic school. And frankly, you can still look like a total badass while looking at these in the hospital, using these rules, and not have to really know that offhand. Although maybe if you want to be super awesome, I'm sure there's at least one medic here who would probably actually commit that to memory and be able to really work with it. Sorry to disappoint you, I'm not that person. So somebody could, but it's probably not me. So there are a number of methods used to do some deeper analysis. We can stop right there for a second and say, what I've shown you right now, you can just look at those numbers and infer some things about, it's weird, I kind of lost something. Oh, here we are. Yeah, never mind. So there are a number of methods that can be used to infer more things about what is the cause of the patient's acidosis or alkalosis than this particular method. Some of them allow you to delve deeper, and I've actually simplified this method. So this is what's called the anion gap method. The other big one is what's called the base excess. These are both calculations that I have actually listed out for you. However, most typical ABG results will actually calculate these for you. So you could expect to essentially see a calculated anion gap and or a calculated base excess. I'm not going to talk about base excess today, but basically what either one of these is doing is allowing you to not just look at, okay, so we have the blood gas and we know something about the patient's overall status related just to the blood gas numbers, but I want to take this and I want to do some diagnostics that tell me why do I think the patient has derangement. And obviously this is going to factor into overall clinical assessment. So in other words, you cannot just look at the page and say 100%, oh, this is what's going on, at least in most circumstances. But you can use these along with your physical assessment of the patient and history taking to make some determinations about what is really wrong with this person at all. So the first thing that you're going to want to do if you are using this method, and we're pretending that we don't have a lab that is doing these calculations for us in part, but this is actually an important step, is we want to look at the validity of the blood gas result to begin with. So in other words, one of the things that can happen, and one of the big reasons that this can happen is because certain states, especially what we call hyper or hypoosmolar states, can make you get numbers from your blood gas reading that are actually just false numbers. Because because we're dealing with electrolytes here, there are some other charged chemicals in your body that we're ignoring because normally their concentration is so small they don't matter. But if the person is, for example, hypoalbunemic or hyperalbunemic, or if they're severely hyper or hypoglycemic, these actually have ionic charge to them as well, and they can start to screw with our numbers because they're becoming part of a chemical formula that we didn't expect them to be, or they were so small that we just pushed them off and said it doesn't matter. Does that make sense? So the first thing that we're going to do is we're going to look and we're going to see, is our pH actually a valid pH? And that's most commonly looked at using something called the Henderson-Hasselbalch equation, which is literally that your hydrogen is going to be 24 times, and remember, we're going to assume the units that we're using here are millimeters of mercury and whatever I said for bicarb, milliequivalents per liter. So 24 times your PaCO2 divided by your bicarbonate, your HCO3, should equal the number that is your actual hydrogen ion concentration. And we would then compare that number to the pH that we're getting out of our blood gas. Because remember, the blood gas is going to return you a pH number. It's not going to return you an H plus concentration number. And we're going to see, does this make sense? Does the number that we're getting actually correlate to the hydrogen ion concentration that we expect that we have based on our other numbers? And essentially, there's a table, and if you wanted to be totally awesome, you could just print this table out and stick it in the back of a field guide somewhere. But roughly, if we look at it, we're looking for a pH of 7.0 on the low end to 7.6 on the high end, assuming that essentially if the patient's outside of these numbers, they're not alive. So, and even at 7, if you've ever seen somebody like at a 7, sometimes you'll bring in like a really, typically the kind of patient you'll see coming in at 7 is like you're really, really, really down the tubes, like sepsis patients, for example, and the person you have fought to keep them alive the whole way in the hospital, and then maybe somebody, if you're like me anyway, you say, you're kind of poking around the room after the call, and you're like, what, did you get a blood gas on them? What was it? And the worst I've ever heard is like 6.9, but usually those people are dead before you walk out the doors of the ED, and even at a 7, you can pretty much assume that you should be proud of yourself for keeping them alive to the ED because they're probably extremely hemodynamically unstable. They don't saturate well at that pH. They don't do pretty much anything well at that pH. In other words, though, if we returned a pH of 7 and we ran this Henderson-Hasselbalch equation, we would expect that our hydrogen ion concentration in millimoles per liter would be 100. So if we, and so on and so forth on the list. So if we do the concentration and we get a very, and this is rough. If it was a little bit off, I would say we're probably fine because there's going to be some sampling error inherent in doing these tests. But if it's vastly deranged, then pretty much you can say, hey, I'm getting this crazy pH number or this normal pH number out of my machine, but there's a problem. This isn't a real number, so we could potentially resample, look at an older sample, or discount that and look at some other lab to see, is there an expected cause of derangement? Do we have some other things that are acting like ions happening inside the patient that we didn't expect? And we should maybe look for those. We should look to see, like, so for example, why would somebody's albumin be deranged? What's a really common reason that we have albumin derangements in patients? Somebody knows this. Burns will absolutely derange albumin. What's another one? The one that comes to mind immediately. So where does albumin come from in your body? Where does that get cranked from into your serum? So it comes out of liver, right? So in liver disease, and we see this clinically in patients that we assess. So like, for example, what is like a very, very common finding? What's a really common reason that we transport people with liver failure? Discounting altered mental status, although altered mental status can be related to albumin problems too. But what's like a really, why do people call? They have like mid-stage liver failure patients. They're not dying right now, but they're in a lot of distress. They need to go to ED. What's the reason? What's the big? Ascites. Why do we have ascites? We have ascites because we're hyperalbuminic, right? Because essentially their liver is not able to produce the amount of albumin necessary to make their blood have normal osmotic pressure. So their osmolality is often, they have leakage from capillaries leaking into their abdomen and causing this huge swollen abdomen. Say what?
Because it's not, like you said, the osmolality is not enough to pull the fluids back.
Exactly. So in other words, the reason I even bring this up is if we're seeing derangement in some of these tests that we do to say, like, hey, are these ABG numbers real? We have to start looking for things that can derange that, right? And that could be one of the things. So step 2 is we're going to look at the patient's pH for acidemia or alkalemia. This is easy. I don't really have much to say about this. We're going to look at the number, and we've validated the number. We're going to look at the number and say, is the patient either A, normal, B, acidotic, or C, alkalotic? And we're going to note that. And then step 3, and this is honestly, and this is why I struggle making this presentation, this is the most important thing in my perspective. As a paramedic, you know about this that you probably wouldn't know otherwise, which is looking for respiratory or metabolic derangement if there is derangement. And we can look at that so there's a lot of other things that I'm going to touch on in the last little bit of this that I think are less important, but remember this slide. This is the thing to remember because essentially we can look at an ABG And we can, under normal circumstances, determine one of three things. We can determine this is most definitely a primary respiratory acidosis, a primary metabolic acidosis, a primary respiratory alkalosis, or a primary metabolic alkalosis, or it's mixed because it doesn't meet any of these, right? So essentially, if we have a respiratory acidosis, the pH will be below normal and the PaCO2 will be above normal. If we have a metabolic acidosis, the pH will be below normal and the PaCO2 will be below normal. If we have a respiratory alkalosis, the pH will be above normal. And so, I mean, you can see it. Can the people in computer land see it, or I need to say it out loud?
They should be able to see it.
They can see it. So remember, instead of, this is 4 things to remember with little arrows. Think about it this way. In metabolic disorders, pH and PaCO2 change in the same direction. In respiratory disorders, they change in opposite directions. So in other words, if we see the pH and the PaCO2 either too high together or too low together, that is a metabolic problem, right? Either metabolic acidosis or metabolic alkalosis, right? And frankly, I care about that because I know this person has instability. As a paramedic, I'm less worried about going deeper because there's not a lot that I can do clinically about that. Now, of course, we're assuming this is probably on a transfer that we've been seeing this, so perhaps, assuming that you're not transporting from some terrible hospital that doesn't know what they're doing for the patient, this has been noted, and if indicated impossible, some therapy has been initiated, either if it's like, say this is a tox problem, GI decontamination or some kind of medication infusion has been initiated to attempt to correct this, and that's why you then would have to manage this medication. You should probably know why you're doing this and what that is, but hopefully there's some other clues at that point for you. But if it's respiratory, this is good to know because essentially I can say, oh, hey, we're changing opposite directions. Our pH is down, our PaCO2 is up. We know that this person has a primary respiratory problem. They're acidotic, so they are severely ill from respiratory disease, and that's the cause. And that's all. And literally, there wasn't anything more to know. But there's technically 3 more steps. There's really only 2 more that I could begin to even touch upon in this. Let's talk about the other couple steps.
And just to tag on to this slide as well, like Zach said, metabolic, the pH and the PaCO2 are going to be equal. And respiratory is the opposite.
Exactly.
For the acronym people, we have acronyms for everything in medicine. And another one for this, it's ROME, R-O-M-E, so respiratory opposite, metabolic equal. So
I'm impressed, Tim. This is great. This is great. Any questions? So anybody out in computer land? I don't know if anybody's still listening.
Zach, I got a question for you.
Shoot.
First off, Tim, you're a little quiet there. But I'm wondering how much effect respiratory compensation is having on this. Are we seeing the PaCO2 go down in metabolic acidosis because they're having respiratory compensation, or is that just kind of the natural flow for seeing these things?
Well, that's a good question. So,
can you repeat the question?
So what Alex said was, are we seeing PaCO2 go down in metabolic acidosis because there's respiratory compensation, or is there another reason? And I'm going to say that's a hard question for me to answer, but yes, short answer, yes, we are. And that's the reason why, essentially, there is a respiratory acidosis because they have a ventilatory failure. The person cannot ventilate enough. If they could ventilate appropriately, they wouldn't have an elevated PaCO2 and they wouldn't be acidotic. And so in metabolic acidosis, the PaCO2 is down essentially because that's not the cause of their acidosis. They're able to breathe off enough CO2, but they have an intrinsic process going on. Either they have a toxicological process or a disease process of some kind going on that is decreasing their pH independent of their carbon dioxide level.
And if it's metabolic cause, it's usually some derangement of the ACO3 ion.
Exactly. Yeah,
it's either not being excreted enough by the kidney or enough of it being spilled out.
And you got to speak loud, Tim, because I can't hear you that well. But
I'm trying. I got the settings on that a little bit different. And so, like Zach was mentioning, the respiratory, that's definitely going to affect the CO2 values. And if they have metabolic acidosis or alkalosis, it's because of some derangement involving the bicarbonate or the HCO3 ion. So
or they have
problem.
literally ingested fixed acid of some kind, or something
Right.
that is being metabolized into fixed acid.
Right.
And they, or a lot of times, honestly, your metabolic alkaloses are what I would say more commonly associated with tox, although there are some big tox ones that we know, especially aspirin overdose is a big one, or massive cocaine overdose.
Right.
For some reason, and this is honestly, I don't have a good answer for this, but in kind of researching this to put this together, a lot of things associated with sodium channel blockade also produce pretty significant acidosis, and I don't know exactly why, but I sure would like to. I didn't have time to really.
Yeah, I wonder if it has anything to do with the renal involvement and the
in electrolyte.
sodium.
Yeah, I don't know the answer to that, but Alex, I hope that answers your question. Anybody else have any questions? Alex, you have any follow-up questions for that? I don't know. I'm going to take it as a no, I think. All right.
Silence is a no.
So then we're going to assess compensation. And there is a very complex formula that you can use. And I would be happy to, actually, if you're interested, send out the documentation that I have used to derive this lecture from. But it involves looking at the delta of your anion gap versus your current anion gap versus the delta of your bicarb versus your current bicarb. And I thought to myself, honestly, I could not do this on the fly myself. And so I would not I would not want to include this in a lecture that I know it's not going to be clinically useful at all to anybody here. But the gist of this is, if disturbances in pH and CO2 do not correlate as expected, or it's a really high derangement, then we likely have a mixed cause. So in other words, the patient can have a respiratory and a metabolic acidosis at the same time. Think about it, from a kind of 10,000 foot perspective. What would be a reason that we would have a respiratory and metabolic alkalosis? An easy one to think of at the same time. So what would be a drug that we kind of are familiar with that people sometimes ingest, like in suicide attempts, that can cause this kind of problem together? If we acutely got a blood gas that had not been really fully worked up, we would see this kind of mix. Any ideas? So the answer to that would be thinking about a TCA overdose. So TCA overdose will cause a metabolic acidosis, but it will also cause is respiratory depression. So if the person is not breathing with enough rate and depth to basically maintain homeostasis through off-gassing with CO2, and they also have something that's interrupting bicarbonate production or utilization, the person will have, this is why these people die really quickly, and you find them breathing 4 times a minute with a wide complex tachycardia, is because we have basically paralysis of the respiratory centers, and we also have an agent in their body that is causing production of fixed acid and impairment of buffering, and it's bad. But anyway, so that's step 4 for what it's worth. Step 5 is going to calculate the anion gap, and this is something that you actually could do pretty easily. So on a typical blood gas report, and this is just to clarify, this would not be the case on something you got out of an iStat, although if you felt the need to, if you had an iStat, you could use another cartridge to look at do an electrolyte panel. But your typical hospital ABG or VBG will also give you some basic ions as well, because they're important to calculating the anion gap, or likely just give you an anion gap calculation from the lab. And the anion gap is literally, once again, if you look on the internet, which I'm hoping that some of you might be like me and be like, is Zach really just making this all up, or is he actually? There's actually a variety of ways to calculate this. So I have given you the simplest formula. Some also include potassium, because potassium is another positive ion. However, there's not nearly as much potassium as there is sodium, as it matters. So typically, the quick and dirty way to say what your anion gap is to look at your sodium minus your chloride plus your bicarbonate, and that number is your anion gap. Now, once again, to get back to where I was maybe 10 minutes ago, remember there are other chemicals that potentially can be exerting ionic forces within your serum that we're ignoring when we're calculating this anion gap, which is going to be especially some of your large molecules that they have some charge to them, and they can screw this up. So if you do this, or if you have an anion gap calculated for you, and you basically are like, this doesn't make sense. This thing is really high, or it's normal, and it shouldn't be. very likely you have to then delve deeper and say, hey, there may be something else going on with this patient, some other lab we'd want to look at that explains why it's giving me a result that doesn't make sense clinically for the patient. But assuming that's not the case, and remember, I only really care about anion gap for our purposes and for most emergency medicine purposes if we're talking about an acidotic patient. We can look at, essentially we'll get high, normal, or low. So if we have, and there's, once again, as I know, Tim might even have another mnemonic. I just picked the simplest mnemonic because this one can get broken down into like a 10-letter mnemonic, or 10-letter mnemonic, right? Yeah, I guess. That can break you down a lot more into what you think the possible causes are. But let's assume that we just want to keep things simple, because I know I sure as heck do. LKTR, lacter, which is lactate, ketones, toxins, and renal. In other words, we have an acidotic patient, we've calculated our anion gap, and it's above 12 milliequivalents per liter. We're going to presume that the cause of our acidosis is either a person has excessive lactate, they have high ketones, there's some toxicological cause, or there's a problem with buffering. Renal failure is your primary cause. Does that make sense? Any questions about that? And we can break this down more, but I think for our purposes, that's far enough. And then we have normal, which is CAGE, which is hyperchloremia, acetazolamide or Addison's disease, GI causes, and then extra. And extra is a weird one, which in this case, we talk about RTA, which is renal tubular acidosis, which we would associate with. Oh, hi, Jeff. Jeff's here to judge me now, everyone.
No, I'm not. I'm just going to say hi, and I'm out.
Hi, Jeff. It's good to see you, man. But so renal tubular acidosis could be a cause of a normal anion gap acidosis. And then low, typically, if we have a low anion gap patient acidotic, we know that we're missing something. Either we have the lab or us has screwed up or the machine has made an error and we actually don't have the numbers we think we have, or there's unmeasured ions. There's an osmolar gap. And if you felt the need, you can calculate the osmolar gap by looking at some of these these high osmolarity chemicals, like specifically, the big ones are albumin and glucose. We could calculate those. We could put them in another formula. We could remeasure. But let's just say for our purposes, the number's low, there's invalidity in the formula, and something else is going on with the patient. Any questions about that? No? And I think that's it. That's the end of that. So I hope that was enlightening